Good afternoon, everyone. My name is Dr. Eileen West. I'm a general internist in Fairfax, Virginia. Thank you for joining us on Facebook Live today. I'm very excited to introduce a gynecologist named Dr. Nadine Hammoud, who is here with us today. And we are going to be having a discussion about polycystic ovary syndrome. PCOS is very common. Up to 10% of women struggle with this disease. And unfortunately, there's a large number of people who do not ever get properly diagnosed or treated for it. So one of the things that we want to do today is tell you everything you need to know about PCOS so that if you have symptoms that might be similar, you can talk to your doctor about it. If you are wrestling with any problems that are similar, then you know that this may ring a bell and may help to get you the help that you need. So, all right. Dr. Hammoud is a native of Beirut, Lebanon. She has her dream since childhood has been to become a physician and help patients. She attended the American University of Beirut Medical Center and got her medical degree with honors there. Then she completed her OBGYN residency with an outstanding rank at Inova Fairfax Hospital. She has been awarded multiple awards, such as the Laparoscopic Skills Award, a recognition of excellence in minimally invasive gynecology, and a Resident Achievement Award, among others. She's also very active in education and research. She used to serve as assistant clinical professor for Virginia Commonwealth University through their North Campus at Inova, and currently is working with the University of Virginia students at Inova. In her spare time, she enjoys spending time with family and friends. She's a big fan of outdoor activities like hiking, photographing, and the beautiful nature, and swimming. She loves to travel and explore new cultures and meet people from all over the world. So welcome. Happy to have you, Dr. Hammoud.
Yes, absolutely. Well, thank you, Dr. West, for this very nice introduction. And welcome everyone to our Facebook Live, where we're going to be talking about polycystic ovary symptoms. And if you have any questions, please let us know in the comments or at the end, where we will be opening the discussion for question and answers. All right, so today we're going to be talking about what is polycystic ovarian syndrome, or PCOS. What are the symptoms of PCOS? How is it diagnosed? What are the types of PCOS? And what is the general treatment? So what is PCOS? PCOS is actually the most common endocrine disorder affecting reproductive aged women, and it has a prevalence between 8 to 13%. Now, there is no universally accepted definition of PCOS because it's a complex condition, and it's most often diagnosed by the presence of 2 of the 3 following criteria, which we'll be talking a little bit more about it later on. High androgen, ovulatory dysfunction, and polycystic looking ovaries on ultrasound. So you guys need to have 2 of these 3 criteria for us providers to suspect PCOS. Now, because these findings may have multiple other cases other than PCOS, we have to have a careful and targeted history and physical exam to ensure appropriate diagnosis and treatment. Now, where does it come from? PCOS is currently thought to emerge from a complex interaction of genetics and environmental traits. It's a multifactorial disease, and the different susceptibility of patients is probably determined by several genetic and environmental risk factors. So we can have 2 sisters from the same family, and one could have PCOS and the other might not. And this is, again, why the importance of other environmental factors. So The pathogenesis of PCOS is usually linked to an imbalance in hormones, which is usually the LH hormones, insulin resistance, which is a big buzzword if you ever heard of it, and a possible predisposition to high androgen in your body. So how is it diagnosed? We always have to have a thorough history and physical exam. We go over the menstrual cycle of the patient. We ask about any fluctuations in patient's weight. And like we mentioned, we always have to exclude other diagnoses that could resemble PCOS or other ovulatory dysfunction. So this is just a box listing other factors just for us to consider in the differential diagnosis of PCOS. Just to give you examples, women with thyroid disease or high prolactin levels or other types of hormonal disorder and possibly tumors could present with symptoms similar to PCOS. So we have to keep in mind that other syndromes could be present. We always get asked about types of PCOS, and we have several classifications for PCOS. This classification lists PCOS as 4 types, type A, B, C, and D. And the difference between these types, we look at the androgens level, which androgen is a hormone mainly for male, it's like the male hormones, but we women do have it. So we look at the androgens hormones and the symptoms of high androgens. We look at the periods and we look at the ultrasounds looking for polycystic looking ovaries. So these are the 3 factors. And if you think about it, you can have multiple algorithm and hence multiple types. For example, type A has high androgens with irregular periods, but and polycystic looking ovaries on ultrasound. It has all 3. Type B has the high androgens, has the irregular periods, but normal looking ovaries on ultrasound. Type C has high androgens, regular periods, and polycystic looking ovaries on ultrasound. And you know it by now, type D would be normal androgens, irregular cycles, and polycystic looking ovaries. Now, it does sometimes matter which type of PCOS you might have because it does differ in the treatment plan that we have for you. Another classification of PCOS is the following. It's insulin resistance, which is the most common. Pill-induced PCOS, so after a woman has been on the birth control pills, she might manifest with symptoms similar to PCOS. Inflammatory PCOS, adrenal PCOS. So again, just another classification where we look a little bit more at the pathophysiology. For example, the insulin-resistant PCOS, which, again, the most common type, has high insulin level in it, leading to insulin resistance. The pill-induced, like we mentioned, usually after many years of use of the PCOS, which might alter sometimes the ovulation and lead to symptoms that can mimic the full-blown spectrum of PCOS. Inflammatory PCOS, like the name tells, it just manifests with high level of inflammation in the body, giving inflammatory ovaries and inflammatory hormonal axis. The adrenal PCOS usually manifests with high levels of one hormone called DHEAS, but it's the least common type of PCOS.
Dr. Hammoud, could you just, there's a question here about what age group is most affected by PCOS.
So that's a very important question. We will get to how we diagnose PCOS, especially in the younger population. But to answer your question, we usually don't start evaluating a reproductive age woman, I would say starting 18 plus, because in adolescent, there's a whole different algorithm to diagnose PCOS. I would like to add another classification of PCOS actually, which is the lean PCOS and PCOS who might have a little bit higher BMI. A lot of women and practitioners, unfortunately, do not know the different classification of PCOS, and this is why it could be underdiagnosed sometimes. But also we have the lean PCOS, which would have women who have normal BMI. So just keep that in mind. A lot of whether out there on Google or on regular websites, they might always say that the patient have to be overweight, but this is not true. Even lean with normal BMI women might actually have PCOS. So what are the symptoms of PCOS? How could you tell if I have PCOS or if I have any symptoms that could be part of the spectrum of PCOS, and if you need to be evaluated for that? So again, the symptoms are very variable, like we talked about. A woman could be totally asymptomatic, or she might have multiple other either gynecological reproductive problems, dermatological meaning skin or acne problems, or metabolic meaning medical health manifestations. And the signs of high androgen and a constellation of irregular periods or no periods, and sometimes infertility. So this is what we call the associated metabolical or health conditions that could, unfortunately, one with PCOS could have. And since Dr. Eileen West is here and she will be taking care of that, if you want to discuss the potential metabolic concerns that we have for PCOS.
Sure. Well, a lot of people are familiar with the term metabolic syndrome. And it is basically a condition of a little bit elevated blood pressure, a little bit elevated blood sugar, a little bit of elevated cholesterol, and overweight or increased waist circumference. And metabolic syndrome is clearly associated with increased risk for cardiovascular disease. In fact, so much so that we treat it pretty much like those who have diabetes when we're managing. So the biggest concern is cardiovascular, and we want to make certain that we are managing cardiovascular risk factors in anybody who has some of these issues or all of these issues together. There's a clear association between metabolic syndrome and polycystic ovary syndrome.
So this is why it's very important for women with PCOS, once they are diagnosed with PCOS, to follow up with their primary care doctors, because they need to be screened for all what Dr. West just mentioned about the potential associated implications, medical implications of PCOS.
And we worry about other things as well, sleep apnea and dermatologic conditions like acne and excessive hair growth. And also it's associated with mood changes as well. So anxiety, low-level depression, and full depression.
All right, so to diagnose PCOS, we mentioned we have to talk to the patient always. We have to listen to the patient. We have to know her history. What are her concerns? How are her periods? And we indirectly would be asking her questions that in the back of our head, like, are we ruling in or are we ruling out PCOS? We do a good physical exam, looking from head to toes for the skin, excessive hair growth in unwanted places. We look at the pelvic exam to see if there's any masses. And then we get basic blood tests, which is most of the time hormones, but also other blood tests to rule out the other medical conditions that might mimic PCOS. And we can add ultrasounds. However, ultrasounds are not always needed, just like we mentioned, that we need to have 2 of the 3 criteria to diagnose PCOS. And again, depending on the types of PCOS, we can have a normal looking ovary, but the patient would still be diagnosed with PCOS if she has the 2 other criteria. And what we call hyperandrogenism, again, it's usually either clinically, so we look at the patient and we see She might have excess acne, or what we call androgenic alopecia, which is the balding in the front. Hirsutism, which is the excessive hair in unwanted place, like we see in this picture on the chin or upper lip or on the sides. We can also diagnose high androgens by the blood, and usually we test for testosterone or DHEAS. All right, so just some definitions for the public, and I apologize if it's a little bit too much detailed, but it's important for the woman to know what do we mean by ovulatory dysfunction or oligomenorrhea. This is how you can monitor your own cycles, and you can tell, all right, am I having a normal cycle, or is this considered oligomenorrhea, hence ovulatory dysfunction? And these are usually cycles more than 35 days apart, but less than 6 months apart. So this is what we call oligomenorrhea. Amenorrhea, meaning, no cycles at all. And usually we wait a good 6 months before we call the patient if she has previously irregular cycles to be amenorrhea. Now, what do we call a polycystic looking ovary on ultrasound? These are the definition. Usually the ovary would contain 12 or more follicles, the measuring 2 to 9 millimeter in diameter, or even just the one ovary, the volume of that is greater than 10 milliliter on ultrasound. And this is actually the radiologist would measure this. So if you guys are reading your report, you know why we are measuring the volume of the ovary or the number of follicles. Like we mentioned, ultrasound of the ovaries is not always necessary unless we want to rule out tumors or the patient's having some pelvic pain that we want to rule out a large cyst. So now we diagnose PCOS, what is next? What are the treatment of PCOS? We always have to remember each patient is unique, each patient is different. So we usually individualize our treatment based on the patient's presentation, what are her symptoms, but also her desire to get pregnant or not. So I made this table to maybe summarize like a whole textbook of treatment of polycystic ovary syndrome. So we can start with menstrual irregularity. So again, most women have irregular periods. So usually the treatment of choice would be hormonal contraception, such as the regular birth control pills, the patch, the depot shot, the progesterone-only pill, the vaginal ring, or an Mirena IUD. For the hirsutism, which means excessive hair growth, our first-line treatment would still be the birth control pills, because one of the mechanisms how they work, they lower the sex hormone binding globulin, hence they lower the circulating testosterone that could increase acne and hirsutism. We could add the spironolactone, which a lot of patients might be familiar with that, and newer maybe off-label medications such as the flutamide, the Vanicap, they are still under studies. Some patients use them, but they have their own side effects. And always we recommend laser treatment. For the acne, it's similar, hormonal birth control, the anti-androgen spironolactone. For women suffering from infertility, luckily we do have 2 great drugs that we can help women with PCOS achieve pregnancy. These are Clomid and letrozole. If you've heard of Clomid, is the most popular, but newer studies actually show that letrozole could be used first to help women with PCOS to get pregnant. Now, a lot of women with PCOS, unfortunately, might be at risk of what we call endometrial hyperplasia. Endometrial meaning the lining of the uterus or the womb. So, and hyperplasia meaning abnormal thickening. Unfortunately, this could progress to precancer and cancer. And the treatment to that, again, luckily, is just the Mirena IUD, which is usually used for birth control, but it actually is FDA approved to use in women who might have abnormal thickening of the lining in the case of PCOS. Now, the other metabolic manifestation or metabolic condition that we talked about, always we have to start with lifestyle modification, leading a healthy lifestyle, healthy diet, weight loss, and metformin, which is a drug that we use to treat diabetes, has also been shown to help women with PCOS, especially the insulin-resistant type PCOS, to either regulate their period or lower their pre-diabetes risk and their other metabolic problems.
And as I understand it, Dr. Hammoud, the weight loss that's necessary isn't necessarily a huge amount of weight.
Correct.
It's maybe 10 or 15 pounds, like 5% of a person's body weight if they're overweight.
Correct.
And some people, you know, aren't overweight with this condition. So the weight loss isn't the most important thing.
Correct.
And what I also read recently was that changing your exercise routine and getting really clear about a healthy diet with lots of fresh fruits and vegetables, lean protein sources, really cutting out processed food and sugar and too much caffeine and too much alcohol.
Absolutely.
All of those changes can work almost as well, if not as well, 100%. As taking medicine.
Yes.
Is that right?
Yes, ma'am.
Yeah.
I agree. So we have a lot of newer guidelines about inflammatory diet, about inflammatory, unfortunately, supplements. All of that could definitely be helpful in managing PCOS. We do not always, and I personally do not always like to throw medications at patients. So we always start first with lifestyle modification, counseling on what type of PCOS she has, so we can guide her treatment. But I agree, the weight loss, 10 to 15% is enough. Not obviously like, you know, over 2 weeks, but gradually, and a healthy diet. And then we give the patient few months to see how she's doing with the conservative management first. And if she fails, then this is where we could discuss with her other treatment option. So the goals for our treatment would be treating the infertility, treating regulating the menses for endometrial protection, controlling the high androgen features, again, addressing metabolic complications. So all patients need to have a routine blood pressure evaluation. We ask them to have primary care health checkup every year to get a regular blood test. So the lipid panel to rule out if they are at risk of high cholesterol, not necessarily the 2-hour glucose test, but at least the pre-diabetes check or the diabetes check. Dr. West, you usually screen for sleep apnea in your practice, correct?
Yeah, we do 2 questionnaires for every patient.
Okay, very good. So this is very important because patients might not be aware of it, and obviously sleep apnea definitely, if not diagnosed properly and early, could lead to cardiac and I understand also pulmonary dysfunction. We should screen patients for depression. And like Dr. West mentioned, lifestyle modifications and weight reduction reduce the insulin resistance, and in many patients is only successful with regulating their period and helping them ovulate sometimes. So a very important question, unfortunately, is, you know, PCOS is underdiagnosed. A lot of women in their 30s start talking to their doctors about it, which is not ideal. But why is it underdiagnosed? One, it's because it's a complex reproductive, hormonal, and psychological features. So even us as providers, we have many types. Not all providers, unfortunately, are aware of the many types of PCOS. I counsel my patients that it's a spectrum, really. It's not cut and dry. It's not like, you know, someone like diabetes is like one number above which you will be diagnosed with diabetes. PCOS, and it's hormones. We're talking about female hormones, and we're very complicated. So it's a complex syndrome. So we have, one, the patient should be feeling comfortable discussing those symptoms that she has, and the doctor needs also to be aware of what the PCOS in the back of our mind. because also the clinical presentation of PCOS in patients is inconsistent, and we have many definitions for PCOS. Again, this is why it's not as simple as to diagnose one with PCOS. And like we talked about, there are other conditions that mimic PCOS. So maybe sometimes the patient or her doctor are focusing on one diagnosis and missing the differential that this could be PCOS. Now, to answer some of the questions, when do we start diagnosing PCOS? So in adolescence and when the patient starts menstruating, it's very common for the woman not to have regular monthly periods. This is what we call the hypothalamic immaturity, where like the brain and the hormones are still trying to figure out this new hormonal spike. So anovulation and irregular cycles are very common. So this is why we do not like to label young women at a young age with PCOS. Usually guidelines tell us to wait at least 2 years, to delay the workup for at least 2 years before starting that, okay, we need to work you up for PCOS. And if we are going to diagnose an adolescent with PCOS, some societal guidelines suggested that the patient meets all 3 criteria before labeling her and start to give her all this emotional effect that, oh, you have a medical condition. So this is the difference between I would say 18 plus and adolescents. I think I hope this information will guide you in your health, but we're going to open the floor for both of us to answer your questions. So I think we have. All right. So let's go. Are patients with higher BMI at higher risk of having PCOS? Not necessarily, but it's the other way around. Most women with PCOS, and I think it said like almost half, like 50% of women with PCOS might be overweight and obese. And given that insulin resistant type is the most common, and maybe you could also answer why is weight loss is so difficult. When we have insulin resistance, unfortunately, the body, and maybe Dr. Russ, you can actually even talk more about insulin resistance. The body tries to hang on to the fat in the body. The metabolism is not as quick. The liver and the pancreas are not functioning in a very good way for the brain to know that, okay, we need to burn this fat. We need to lose weight. But if you want to talk more about insulin resistance, I think you're the expert in that.
Well, the insulin resistance is a very real problem for many people, and it basically what it means is that our bodies enter a more reactionary or inflammatory kind of general state. It's a chronic inflammatory condition, and as a result, it takes more insulin to drive the blood sugar that's in our bloodstreams into our cells, our fat cells, to store it, or into our other cells to utilize it, like our muscle cells, for example. So the body finds itself having to work a lot harder to keep blood sugar normalized. And so its first reaction is to make a bunch more insulin. And so that's why sometimes people will see spikes and drops and spikes and drops in blood sugar. They may not feel very well. When the blood sugar goes high and your body makes a lot more insulin, then it can drop quickly. That can lead to cravings for carbohydrates or for sweet foods to try to normalize the blood sugar. And it's the biggest risk, of course, is all of the diabetes that can then come of it. Pre-diabetes, about 50% of the time, people with pre-diabetes end up eventually with full-blown diabetes because the pancreas just gets tired and it stops being able to make the insulin.
Yeah. So even if some women are trying to exercise, eat healthier, the body just like is hanging on to all of this. And the key is not like to starve our body, because if anything, the reflex is going to keep more of those calories inside of us. So it's usually just more exercise. And again, like Dr. Russ mentioned earlier, a healthy diet, so non-inflammatory diet low in carbohydrates, high in healthy fats and protein. So we have what are some key indicators of PCOS? So really the big three, I would say, irregular periods. So cycles are not very regular, or even no periods at all. Like, you know, a woman would be telling me she has a period twice a year. High androgens, so symptoms of high androgens, whether clinically, so acne, excessive hair growth in unwanted places, or by blood test. So high androgen hormonal level of testosterone, or the DHEA as we talked about. And 3, polycystic looking ovaries on ultrasound. So I would say if these are the key indicators that, you know, if someone's presenting with this is the first thing I would think about. If a woman is having trouble with fertility, how would she rule out PCOS? So again, to diagnose PCOS, we usually need to take a good history from the patient. Not only fertility is definitely on the list, but again, infertility is a much more complicated discussion than a woman just having PCOS. So I would actually go the other way around. I would start with a good history to go over her menstrual history, her weight fluctuation, get a physical exam on her, get some blood work on her to see if she has some hormonal imbalance, or her hormones might be consistent with what I would see in a PCOS patient. And I would also get an ultrasound to look at the ovaries. And like we discussed, we only need 2 criteria to tell a woman that yes, you are on the spectrum of PCOS.
I think many times the oral contraceptive is an excellent solution, especially for, you know, younger patients, maybe who aren't ready to have children, and it can help with a lot of the different symptoms.
Correct.
And it helps with the hair growth, and it helps with the irregular cycles, and it helps with the abdominal pain and the, you know, those types of symptoms. But there comes a time for some of these women when they want to become pregnant.
Yes.
And I know a lot of people are a little reluctant to stop the contraceptive because it's been helping them.
Yes.
So tell me how in your practice you manage that transition when someone comes to say that they're ready to start trying to have children. How do you take them off the oral contraceptive? What's the next step?
Yes. Well, first thing, yes, to stop birth control pills or like any type of contraception. We usually tell patients it might take a good 3 months before their body regulate to a normal cycle. Women with PCOS, because they don't usually start with a regular cycle, we might give them a little bit longer. The other factor to consider is timing, right? So some patients might be a little bit more like for lifestyle purposes, they might actually decide I just want to give myself 6 months. Some patients are, you know, if it happens early, great. If it doesn't, then we're all okay. So this is another factor to consider, how aggressive we need to be with treating the patient. We always tell them to start prenatal vitamins the minute they decide to get pregnant, honestly, even maybe before stopping their pills. And then I prefer first to let the patient conceive naturally, right? So whether with the lifestyle modification we talked about, and this is where I would tell her you can give yourself 3 to 6 months of naturally trying to conceive, because some women will still ovulate, you know, they cannot catch it, that's maybe the hard part, but women with PCOS every now and then might ovulate, but it's very hard to track it or catch it. We definitely always say to track their periods, so get an app and track their periods, see whenever they're ovulating to maybe take ovulation kit testing just to increase the success of pregnancy. And then after, you know, they are deemed that they maybe failed by themselves, or like they do not want to wait, I just want to jump to the treatment. We talked about the 2 medication we can help patients with PCOS, which is Clomid and Letrozole. And, you know, each of these medications, we have a good algorithm to treat patients and to see if they fail the first cycle, what's next. If they fail the second cycle, what's next. But luckily with those, one of the other medication they do have a high success rate of conception.
That's great. Yes, very helpful. So does polycystic ovary syndrome just end when you go through menopause?
So that's a very good question. Well, I don't think it ends because in premenopause we have a whole other hormonal imbalance state. So the hormonal imbalance in premenopause sometimes could manifest like PCOS, obviously, because patients in premenopause could start having irregular cycles, right? So we always have to think about that. PCOS usually is more for a reproductive age woman because it's more of a hormonally imbalanced state in this age group. When we get older, I think because some of the metabolic conditions might stay, and this is where I would be concerned. So if the insulin resistance stays, so the woman, if she has a history of PCOS, in menopause she would still be at risk of diabetes or high blood pressure. So that is actually a risk factor for postmenopausal women. But does it end? Well, medically speaking, maybe yes, because yes and no, because our hormones, our FSH gets lower, and our female hormones gets lower. Obviously, FSH gets higher. Yeah, that's a very good question, actually. Are women with PCOS at a high risk of certain cancers? And the answer is yes. We did discuss endometrial hyperplasia. Endometrium meaning the uterus and the lining of the uterus. Hyperplasia is the excess layer, or like the multiplication, the ineffective multiplication of those layers. Unfortunately, this hyperplasia could lead to precancer and cancer. So yes, they are at risk. And this is across like for all types of PCOS. So this is why it's always important to talk to your doctor about your cycles, and for your doctor to always have in the back of our mind that if her cycles are heavy or are very irregular, or even like any abnormality, to consider evaluation of endometrial hyperplasia.
One other question about the hirsutism that people get. It's not just that they have excessive hair growth on the face or the chest, but there's also often a male pattern baldness.
Yes.
And where do people notice that most for women?
Yes. We do have a good classification for hirsutism. And this is, you're right, more of the male distribution. So either like alopecia, so start losing the hair on the scalp, or like upper lip, chin, on the sides, on the neck, like between the breast, lower back, inner thighs, and even abdomen and around the belly button. So this is also maybe one of the symptoms that a woman should always consider, that is there an association? Do I have high androgens? And if it's consistent with the full-blown picture of hirsutism. But again, not all women with PCOS have hirsutism, like we talked about.
And not all women with hirsutism have PCOS,
yes,
right?
Because we have to screen for other types of conditions. So some androgen-secreting tumors, unfortunately, could present very similar to like full-blown hirsutism, and also like irregular cycles, because the hormones would be off.
I thought I read recently that people who are treated with the laser hair removal, combined with the Vanica cream, have better outcomes than those who just use the laser treatment.
Correct.
Is that right?
Yes, the combination is always better than just a single treatment. We talked about like lifestyle, weight loss, and diet. So the more safe, especially if it's safe. For the most part, the laser treatments usually are safe. Vanica is for the most part safe, but also we always have to counsel patients about some of the side effects. But that's true. The combination would always be better than a single treatment. When you say irregular menstrual period, does density also count in this case? Not necessarily. Like the heaviness of the period doesn't necessarily count with the irregular period. However, women who do not shed on a monthly basis, sometimes when they go for like 3 months with no period, their next period will actually be heavy. Why? Because they formed multiple layers and they didn't shed it on a monthly basis. So when they do shed, instead of shedding, this much, they're going to shed this much. So irregular periods just means the cycles are not every like 25 to 30 days. It's always like the definition is usually like more than 35 days in 6 months. The flow by itself is not. We do look at the flow obviously, but it's not in the definition of irregular periods. Does having PCOS lead to nutrient deficiencies? That's a very good question. Not necessarily nutrient deficiencies, because it's a more of a hormonal imbalance state. Now, the insulin resistance and I would say the metabolic condition, I think if the woman has the metabolic syndrome while having PCOS, then she could be at risk of some nutrient deficiency because the body is not able, I would always stress it's an inflammatory mode, right? So the body is not really able to store the good nutrients or like tell the brain that, okay, we're deficient in that. But I wouldn't say necessarily that we have to check regular vitamins on the woman with PCOS. That's a very good question, though. Has there been any recent studies to show if there is a correlation with COVID? In other words, have you seen an increase of patients who have PCOS who had COVID? That would be a great study.
Yeah.
I'm not aware of any studies to this point, but that's a good idea. I mean, if you think about it, it might make sense because if they are insulin resistant or have some inflammatory problems, so their immune system might be off. But usually, not really. Like, there's no correlation. Like women with PCOS would have more risk of the regular flu or the influenza. So I wouldn't say that there's a correlation, but that's a nice study to think of.
Yeah, we know that obesity correlates with more difficult disease course and sometimes worse outcomes. But obesity and PCOS sometimes go together, but not always. So. All right. I'm trying to think if I have other questions for you.
Yes.
Is there a true cure for PCOS?
I really hope so. I really hope so. In the future, PCOS has been present for hundreds of years, and I think because we cannot, unfortunately, like pinpoint for because each patient's presentation is variable, right? So I wish we can have one size fits all for all the women. This is why it's very important for us to individualize each patient, to go over her symptoms, her goals of treatment, what she wants. If, for example, weight loss is her goal, if her desire to get pregnant is her goal, if just regulating her period. So the treatment is usually shaped based on what the patient needs and what are the main symptoms that she has. So unfortunately, because like we talked, it's like a complex condition. It's we have the brain there, we have our ovaries and the insulin resistance. So it's a much more complicated condition than we think it is. Hopefully one day, yes, why not?
Any other questions? What would you like to know about PCOS? While we have Dr. Hammoud, our gynecologist and current expert, on hand. If you can think of any others, put them in the chat for us. We'll be happy to answer them. And if you have been looking for a practice that involves internal medicine and women's health, I just want to put in a plug for the work that I do in Fairfax. My practice is an internal medicine women's health practice. We do see men as well, but the vast majority, it's 75% of the patients are women. And we really have been trained to look carefully with an eye toward what illnesses women may suffer that may be undertreated at this time. And I also, if you want some more information, I'll just put in a plug for Miss Medicine. msmedicine.com is a terrific organization which is looking to build awareness about internal medicine and primary care practices that focus in women's health. We're really aiming to raise the bar on primary care women's health around the country. So if that's something that interests you, have a look. We'd love to talk to you some more about it. So we've got another one. Is there a correlation between PCOS and hidradenitis suppurativa? So for those of you who might not know what hidradenitis suppurativa is, that's the collection of, it can look a little bit like acne, but it's infected follicles which that produce a lot of sebaceous material and can be very problematic for people under their arms or in their groin area. And once people have this condition, it can be very difficult to treat and to maintain. So is there a correlation with PCOS?
I am not aware of any correlation between PCOS, like direct correlation between PCOS and HS. However, if some women might have it, and if there are some that felt like, oh, we have HS and I was also diagnosed with PCOS, the only thing that I would say it might be a correlation. It's like they both can have inflammatory grounds. So one type of PCOS, like we talked about, is inflammatory, and HS usually is because of inflammation of the gland and the flare-up. And this is why I would only think that the correlation could be if a woman has HS and has PCOS, is she might have the inflammatory type of PCOS, and this is why she has both. But usually the high androgens, these dermatological manifestation of PCOS is usually the high androgens, such as a bit of the hirsutism, the acne.
And we know that there is a correlation between hidradenitis and full-blown diabetes. People who struggle with keeping their blood sugar levels low consistently are more likely to struggle with increased inflammation and increased infection. So,
let's get all this one. Let's get the other.
Oops. Oh, let's see. Here we go.
All right. What is the utmost recommendation you give? Oh, this is very good. So I would say healthy lifestyle. Really, this is the best advice I could give any patient, not only for PCOS. So healthy lifestyle, not necessarily, every day waking up at 4 in the morning and, exercising. So healthy lifestyle, healthy diet, stay away from inflammatory food, stay away from processed food, try to take, like antioxidant supplements, exercise, but not necessarily like heavily exercise, because excessive exercise sometimes puts more stress on the body, and if anything might, does the opposite of what we want. Just like healthy level of exercises. Get your regular checkups with your doctors, and maybe I would say the best recommendation, like whatever your body is trying to tell you, please listen to it. Okay, listen to your body, and just talk to your gynecologist or to your primary care. Even if you just a discussion that I have these symptoms, what do you think I have? What can we do for that?
Those are some terrific questions.
Yes, that's why we're here.
Yeah.
All right, so everyone's welcome.
Yes, we're so glad that you decided to join us today. I really hope that you picked up a few good pointers today. This is, after all, Polycystic Ovary Syndrome Awareness Month. So hopefully we have helped to raise your awareness about polycystic ovary syndrome and help us to raise awareness with others. So thank you very much for Dr. Nadine Hammoud from Fairfax Gynecology Group, who is here with us today, and we really appreciate your time.
Well, thank you for having me. This is great. Thank you for having me. I think we need to do, thank you for doing this. By the way, I think this is very important. I always tell patients it's better to get information from, the specialist over, just going online. And, we always think that, the worst case scenario is online. So thank you for doing this, sharing for the public.
Make sure you understand your sources.
Yes, exactly. Thank you for watching.
Thank you so much for joining us, and join us again next month for the next topic. Have a great day.
Bye, everyone.